Thank you for joining us online for our Center for Joint Replacement pre-op education class. My name is Sarah Hewitt and I'm a nurse here at StoneCrest. I will also be joined by Jennifer Baker, a physical therapist at StoneCrest. We do have some objectives for today. I want to make sure that you understand your procedure, what to expect during your hospital stay, the role of your coach. We talk a lot about pain management, what physical and occupational therapy we'll be doing while you're here at the hospital, the expectations we have for you at home, the discharge planning, and then a big purpose of this class is to ease your anxiety and answer any questions that you might have. The role of the care coordinator is one, to teach the pre-op education class that you're watching. I do daily rounds. I'm here Monday through Friday, so I'll be coming in to check on you, see how things are going at home. I'm your advocate, so I want to make sure that you're having a good experience. Also, each morning I will meet with your nurse, our case manager, and one of our therapists, and we'll chat about you, and we'll make sure that we've got everything in line for you to go home. Also, I will call you once you're at home and check on you and make sure things are going well. You will be up on our joint and spine unit. It's a dedicated unit. Our staff went through training so they know how to take care of patients who are having a joint replacement. We do have a rehab room at the end of the hallway, and it has a tub shower combo, and it has a shower bench. And our therapists like the shower bench because it allows you to sit on the outside of the tub, swing your legs over, scoot in, and then stand up. You may need something to sit in during your shower. You may not have that endurance to stand up for your entire shower. We also have a set of stairs that our physical therapist will practice with you so we can mimic your home environment. We do have private rooms, so you will not have any roommates while you're here at the hospital, but you are allowed to have your coach stay with you if you'd like them to. So why do you need a joint replacement? Basically, that joint is worn out, bone on bone. You can't do the things you love to do anymore. You probably have a lot of swelling, and so we want to get you better and back to a more healthier and fulfilling lifestyle. Our doctors, most of them, use a robotic assistive device, and part of that is to help the doctor make more of those precise and accurate cuts. You will have a CT scan prior to your surgery, and what that does is it maps out your joint, and then that kind of shows the doctor how to make those cuts. And on the screen you can see that where the doctor makes the cuts there's green, and they will shave off all that green bone, and that allows for the implants to just fit good and tight. One thing is you may have an extra incision, and that extra incision is to help that robot connect to the space where your knee or hip is, so it knows where it is in space. We'll talk about the knees first. So lots of arthritis in the knee. This picture is probably what your knee looks like currently. And then on the next slide, it shows the joint replacement. So let me show you real quick on that. So this is the knee, and the shiny components are what we're going to replace. Some people think when we're doing a knee replacement, we're literally cutting off the entire knee. We're not. We're just shaving the bone where those components go. So you can kind of see just along the side, that's where those cuts are going to be. And so this top one is your femur, and we'll put that first component on, and it's either going to be cemented or what they call press fitted. It just depends on what your surgeon likes to use. And then the bottom bone is your tibia, and they will shave off all those arthritic surfaces. There's a little post that goes down into the tibia, and it keeps that in place as well. There is a plastic little piece here, and that replaces the cartilage that you lost, and that allows the components to slide nice and smoothly along each other. You also have your patella joint, which is on the front, and sometimes they will also resurface that and put a little plastic piece on that. But this is the knee replacement. The next joint replacement is the hip replacement, and for that one, we are going to replace the ball and the socket. This is your femur, and you've got a stem that goes down into the femur to hold everything, because if you just put a tiny little ball on here, it wouldn't have that stability. So we have to put a stem down into the femur, and then you've got the ball, and then you have your socket, and that socket is lined also with a plastic, so those two components are able to slide along each other. The next thing is our shoulder replacement. So we have a reverse total shoulder and a traditional total shoulder. So a traditional total shoulder is we're using the natural anatomy. This bone right here is your humerus, so your upper arm. It has the ball, and it also has a stem that goes down into the humerus. And then we also replace the socket. And so this is your normal anatomy, and we can literally just replace those components. Now the other joint replacement for shoulder is the reverse total shoulder, and that's literally reversing the two components. And so where the ball was, we now put the socket, which also will still have the stem, and we put the ball where the socket was. The big reason for doing a reverse total shoulder versus a traditional shoulder is your rotator cuff. Your rotator cuff is what moves your arm, your shoulder. And so if that rotator cuff is not good, then we're gonna rely on the deltoid muscle to move your shoulder. So it's this big muscle right here. So if you no longer have a good rotator cuff, then your surgeon will probably elect to do the reverse total shoulder. So there are some risk factors with surgery. The big ones we're going to talk about are blood clots and pulmonary embolism, which we'll go into more detail in just the next couple slides. Blood loss, the risk of getting a blood loss nowadays is actually very low. We give you a special medicine to help with that during your surgery, so the risk of needing a blood transfusion is low. Stiffness or persistent pain, that is a big one for the knee replacement. If you baby it too much, you're not moving that knee like you should, it can get stiff and it's not going to get that range of motion that your surgeon likes. And if that's the case, they will actually take you back into surgery and do what they call a manipulation of the knee to stretch those muscles back out. Also, you could have some scar tissue that can develop. Neurovascular changes, you may have some numbness on the side of your knee. There's a tiny little nerve that they go through, and that can cause a little bit of numbness, but it will not affect any of your walking. Any underlying medical complications or problems with wound healing or anesthesia, that's why we have you go through pre-admission testing and talk with our anesthesiologist. Less likely complications to happen are those damage to the big blood vessels, big nerves, infection, problems with wound healing, and that last one I don't even like to say, but death. But we don't expect that to happen. We want to make sure that you have a safe and successful surgery. So we do want you to know what to look for infection. So running a fever, increased pain, swelling, and drainage at the incision site. Now you are going to have some drainage typically, and that watery, bloody drainage is normal. And when that drainage starts to change color, like green, yellow, cloudy, thick, smelly drainage, we don't want to see that. And so you won't really be able to see that incision right after surgery because it's going to be covered with a special dressing. But what you're going to look for is that redness and heat and swelling around the incision site. We do want you to do a few things to help prevent infection. Of course, washing your hands. Don't let your pets lick your incision, go near your incision. If you have pets that sleep in the bed with you, we don't typically like pets to sleep in the bed with you because they're full of germs. But if you don't have the heart to kick your pet out of the bed, if you can at least put them to the foot of the bed, give them their own covers, you may need to change your bed sheets a little bit more frequently. And then we ourselves as humans are covered with bacteria and we're constantly shedding our skin cells. And so every week we do want you to change your bed sheets until your incision's completely healed. So we are going to talk about those DVTs and the PE. So a DVT is a deep vein thrombosis. It's a blood clot that can form in an arm or a leg, and it's where that blood clot becomes so large that it blocks the flow of blood. A PE, or pulmonary embolism, is a blood clot that happens when a piece of the blood clot you've developed somewhere else in your body breaks loose, it goes through your heart, and it lodges into your lungs. Now there are some risk factors associated with developing blood clots. The first one would be inactivity. That's why we are getting you up and moving the day of your surgery. Also dehydration, we want to make sure you're good and hydrated so your blood isn't so thick. Also hospitalization, we get you up and we get you going home that next day after surgery. Trauma, that's trauma of having the actual joint replacement. Any kind of clotting disorders can increase your risk. Any of those varicose veins with inflammation. Also any kind of hormone replacement, any cancer, obesity, smoking, and your age can all increase your risk. So symptoms of the DVT. Swelling and pain in the arm or leg can be present, and that swelling can be, in the thigh, and the calf, and the ankle, and it typically will not go down with elevation. Also, you may have change in your skin color, so red, blue, or really pale in color. Your extremity may be warm or even cool to the touch. Your pain can be, tender in that area. And then also, that pain is usually gradual when you are getting up and walking. The pain can be sharp, sudden, or even like a muscle cramp. Textbook blood clot is that extremity is going to be red, swollen, warm to the touch, and it's going to be painful. But not everybody's textbook, so you may have one of those symptoms and still have a blood clot present. So if you're just unsure, definitely call your doctor and let them know. Symptoms of a PE, sudden sharp chest pain or back pain. That's worse usually when you try to take a deep breath. Shortness of breath, just that difficulty with your breathing, that rapid breathing. You might have some blood in your sputum, so you're coughing up blood. You might be sweating for no reason. You might be really confused. You might be running a fever. You might be real anxious, apprehensive. You just can't get that deep breath. You're like, something is not right. Your heart might be racing. You're dizzy. Anything like that, you're passing out. You're calling 911 or whatever the quickest route to the hospital is. So how can you reduce your risk? Well, exercise and early mobility is key. We don't want you standing or sitting for long periods of time. We want you to elevate your legs, avoid crossing your legs because that will cut off circulation, controlling your weight, wearing your supportive hose for about 4 to 6 weeks if instructed by your surgeon. So let's talk about the TED hose real quick. So for those of you having a knee and hip replacement, if your surgeon does want you to wear these, you will be getting these thigh-high TED hose. So the thigh-high TED hose will go all the way up to your thigh. One thing with the thigh-high TED hose is sometimes they tend to want to roll down your thigh, and then that is causing a tourniquet on your thigh. So you don't want that to happen. Some people think they can just fold them over each other, and that will typically stop the rolling, but that's also causing double compression on that area. So you don't want to do that either. So if you are having a problem with the TED hose rolling down your thigh, instead of starting them way up high, you're going to start them mid-thigh, and then you'll just have excess hanging off of your toes. You do want to pay attention to the TED hose throughout the day because they tend to want to wrinkle behind the knee and around the ankle, and we don't want that either because that will cut into your circulation, and it defeats the purpose of wearing these. If the doctor has ordered these for you, we will send you home with an extra pair. Okay? If you're having a shoulder replacement and your surgeon has wanted you to wear the TED hose, you'll get the knee-high TED hose, and basically those will go up just to the knee. Again, monitor behind the knee and around the ankle because they can bunch up. They're not one size fits all, so we'll make sure we get you fitted with the appropriate size, but please let us know if they are too tight or on the other hand, they're not tight enough. That way we can make sure you've got the correct size on. Also, in addition to the TED hose, these are called SCDs, sequential compression devices, and these will Velcro around your calf, and they'll hook up to a machine at the end of your bed. They'll squeeze one calf and then the other, and this will also help with that circulation after surgery to help prevent those blood clots. We also will send you home with some blood thinners, and you may be on something as simple as aspirin, or if you're more at high risk of developing a blood clot, your surgeon may send you home with something called Eliquis or Xarelto. So if you're at the hospital and you're having symptoms of a blood clot, definitely let your nurse know right away. If you get home and you're having symptoms of the PE, you're definitely calling 911 or whatever the quickest route to the hospital is. So we want you to have some preparations before having your surgery. So the first thing is smoking. And the reason we tell you smoking is it constricts your blood vessels. And so that oxygen-rich blood isn't going to get to that new joint. Also, we want you to stop drinking alcohol because that's a blood thinner, and we don't want your blood too thin or too thick. We want it right where we need it to be. So avoid drinking alcohol. Also, the joint education class, you guys are watching that now, so you can check that one off. Pre-operative exercises, Jennifer will be going over those with you towards the end of class. And then pre-admission testing. You will come to that before your surgery. We will do your full health history. We'll go over all your medications, prescription and over-the-counter medicines. We'll do some lab work. We'll do an EKG. We'll do a chest x-ray. And we'll do a CT scan of your knee or hip if you're going to have that type of surgery. And then we'll have you sit down and sit with our anesthesiologist. So if there's any issues with anesthesia in the past, we can definitely talk about those. So there are some medications that increase your bleeding before surgery. We want you to stop. So any of those anti-inflammatory medicines like aspirin, Motrin, naproxen, Aleve, Mobic, Celebrex, herbal medicine, fish oil, and vitamin E can all thin your blood. Definitely you want to make sure you contact your prescribing surgeon or physician if you are on any prescription blood thinners like Xarelto, Eliquis, Effient, Any of those, we don't want you to stop those until you've been cleared to. Usually it's around 5 days. So good nutrition before and after surgery is vital for your wound healing. We want you to eat a well-balanced diet. We do like lots of protein and vegetables to help with your wound healing. You do want to restrict your sugar intake. You don't want to have an overload of sugar in your body. Unfortunately, diabetics have an overload of sugar in their body, and that can slow down the healing of their joints. You will have a hemoglobin A1C ordered by your doctor if that's what they want, and basically what that hemoglobin A1C will do is it will see what your blood sugar has been running over the past 2 to 3 months. If it's too high, it's not an acceptable level for your doctor, there's a chance they will delay your surgery until that number goes down. We do want you to eat a heart-healthy diet, which is staying away from the greasy fried foods, salty foods. And then please, any nutrition needs, just make sure you're discussing that with your surgeon so we can get you on the correct diet. So a few things we want you to do to prepare for surgery. One thing is to read your guidebook. This class goes along right with the guidebook, but definitely read over that. It's full of frequently asked questions. It's split up into 3 sections. So the first section is getting the house prepared, the middle section is while you're here at the hospital, and then the third section is all about going home. If you remember, bring that guidebook with you to the hospital and to your doctor's appointments. It's nothing that we need to see, but it's something that, as we're giving you some information, you can stick it in that front pocket and keep it all together. So your coaches can stay. They can be a family member or a friend. They're going to provide comfort and motivation. And so when you don't want to be getting up every hour, they're going to say, it's time to get up. They can observe those therapy sessions. Then both you and your coach will gain the confidence that your coach can take care of you. StoneCrest is a non-smoking facility, so no one can smoke while they're here at the hospital. Our visitor cafeteria hours have, some restrictions. Of course, for you guys having surgery, you will get breakfast, lunch, and dinner every day of the week. But for visitors, our cafeteria is open Monday through Friday for breakfast and lunch. We're closed every day at dinner, and then we're closed on the weekends. That being said, if your family is here and they don't want to leave you, there's a few options. They can, order out, or we have meal tickets for purchase that they can purchase them, and then they can order food off the same menu as you. Then both of your trays will be coming up at the same time. So we want you to bring a few things with you for your surgery. We want a positive winning attitude. We want you a little excited about having this joint replacement. I know having a joint replacement was probably not in the bucket list of items to accomplish in your lifetime, but you probably still have some things you want to do, so we want to get you better. Also, we want you to bring your guidebook. We've already talked about that. Your insurance card and ID. So when you come for pre-admission testing, we will get a copy of that. But just in case you need it for prescriptions or anything, we do like you to have that with you. Give it to your family member or a friend. Also, if you have sleep apnea and use a CPAP machine, we definitely want you to bring that with you to the hospital. Give it a little sprucing up, check the tubing, check the wiring, make sure there's no frayed wire. There's usually a filter in there as well. So we want to make sure that filter and everything is nice and clean. Our biomed technician will look at it and make sure it's safe to use while you're at the hospital. Also, if you were given a shoulder sling, we do want you to bring that with you to the hospital. A lot of times though, if you don't have one, you will get one when you wake up from surgery. If you have a favorite pillow and you can't sleep without it, definitely you can bring that with you. If you do bring your own pillow, put it in a pillowcase other than white, that way it will stand out. Also, any hygiene items, your toothbrush, toothpaste, deodorant, stuff like that, you're more than welcome to bring that. We have all that stuff here at the hospital as well if you don't want to bring it with you. Also, those loose-fitting, comfortable clothes, we actually want you out of your hospital gown. We don't want you in that drafty hospital gown. And then for you guys having a shoulder replacement, we do like either a front button-up shirt, kind of an extra large loose one, or a shirt that has kind of a scoop neck or a larger neck so we can easily get that neck over your shoulder. Also, we want you to leave your valuables, cash, medications at home. We do not want you to self-medicate while you're here at the hospital. If for some reason we don't carry a medication that you take, we'll definitely let your family know, and we will have our pharmacy check it out and we'll lock it up for you. We do want you to remove your nail polish. And also a big thing is protect your skin from cuts and sunburns. If you have any sort of cut or sunburn on your skin, your surgeon is likely to reschedule your surgery as well. Usually it's going to be the extremity that you're having surgery on. So if you have a little cut on a different extremity, it's probably okay, but definitely you need to let your surgeon know about it. Also, go ahead and leave your belongings in the car in the morning. You are going to get here a couple hours before surgery. Your surgery is going to take a couple hours, and then you go to recovery room. So we don't want your family to have to bring all your stuff in the hospital and then bring it all over the place. Just leave it in the car in the morning, and once we get your room number assigned, they can go out and get it. So we do have some daily newsletters, which I call the Cliff Notes to come into class, and this is what I like to go over with you when I come and see you. Also, an incentive pathway. That is kind of the goals to achieve prior to discharge. And then we have your daily homework. And Jennifer will be going over a lot of these with you, but it's a lot about pain management, your mobility, using that assistive device, out of bed for all your meals, the deep breathing exercises, and walking. Enhanced Surgical Recovery, also known as ESR. This is a research-based program, and basically we've done a few different changes throughout your hospital stay to make you have a better experience all the way around. So the night before and morning of surgery, we don't want you to have anything to eat after midnight, but you actually are allowed to have clear liquids 3 hours prior to your surgery. If you were instructed to by the anesthesiologist, you can take your medicine with some water, and you of course can brush your teeth that morning. If instructed, you will get a special carbohydrate drink. And it looks like this. It's made by Ensure. It's not the normal Ensure you would get at the grocery store. It's a special clear Ensure, and it's full of carbohydrates and some electrolytes, and this is going to help keep you hydrated for surgery and give those cells some nutrients during the surgery. If for some reason you do not get this carbohydrate drink, you can do like a sugar-free Gatorade or something else just to get you some hydration. But just in case you get this, you will drink this 3 hours prior to your surgery. Also, we do want you to get a good night's rest. You will be getting up with therapy that afternoon. Any jewelry, any body piercings, we want to make sure that you remove those. And no deodorant, as it's not compatible with the special CHG wash that we have you use. So the CHG wash, you will use that the night before and the morning of your procedure. And let me show you what that looks like. So when you go through pre-admission testing, you will get a bottle of the CHG wash, and you'll get this little poof, this little plastic poof. We definitely want you to use this when you use the wash, because if you used a regular cotton washcloth, the solution in here would bind to the cotton and not your skin. So we want you to use this. So what you'll do is you'll wash your face, your private areas with your soap and water, and then you'll use this special solution. You'll lather up all over the rest of your body. You'll step out of the stream of water and you'll let that sit on your skin for 1 to 2 minutes, and then you do need to rinse it off. And again, you will do this the night before and the morning of your procedure. When you're using the CHG wash, we don't want you to shave your legs, because if you put that on, the CHG wash right after you shave, that could irritate your skin. We of course want you to dry off with a freshly washed towel, and be sure to have those clean bed sheets on the bed. That way you're good for a week where you don't have to worry about changing your bed sheets. Now, if you test positive for MSSA or MRSA, things will be a little bit different. So we will test you for those 2 bacteria that can live in your nose when you come through pre-admission testing. If you are positive for either of those, your doctor's office will call in a prescription for mupirocin. It's an antibiotic ointment that you'll put in both nares twice a day, 5 days leading up to your surgery. You will also use the CHG wash for 5 days, once a day leading up to your surgery, also the morning of your surgery as well. There is a checklist that will be with the bag of the CHG solution and the little poof, and that's just to keep you, on track of, those applications if you need to take them. And if you can, we do like you to bring that mupirocin tube with you to the hospital that morning of surgery. So the day of surgery, you'll check in at the registration desk just like you did for your pre-admission testing appointment. We'll send you back to the waiting area where someone will come and get you. We'll get you prepped and ready. And as soon as we get you prepped and ready, we'll let your family come back and sit with you until you go off for your surgery. So on arrival to the hospital, we'll have you change into a hospital gown. But right before we do that, we're going to put some special wipes on you. So it is going to be the same solution you used when you were getting ready the night before. But it's going to be in a white form, so you're not going to have to rinse these off. There is a diagram on how to use this, and your same-day surgery nurse will show you how to do that. Also, in addition to the wipes, we're going to put povidone iodine in your nose. It's an antiseptic, and we will give that to you regardless if you test positive for the MSSA or MRSA. So when we're getting you ready in same-day surgery, we'll do a head-to-toe assessment. We'll make sure you're feeling well for surgery. We'll put those TEDs and SCDs on like we discussed earlier. You will have an IV started. You don't want to be awake for your surgery. We'll give you that pre-op medication that anesthesia and your surgeon has ordered. We'll give you an IV antibiotic, and typically you'll get a dose of the antibiotic before surgery, and if prescribed by your surgeon, you'll get a dose or two after your surgery as well. We will be asking you the same questions over and over. Who's your doctor? What are you having done? Your name, your birthday, all that stuff. We want to make sure that nothing's changed. It's not that we don't know. It's just it's a safety measure. And then also you will see the anesthesiologist that morning, and you will see your surgeon. So again, any last minute questions for them, they'll be able to answer, and then they will also mark your site so they have that other safety measure for when you're in the operating room. So your joint replacement will take about an hour to an hour and a half for the actual surgery. You'll likely be in the operating room though for about 2 to 2.5 hours, and that's to get you off to sleep, cleanse that skin, and then wake you up after surgery. Sometimes there are delays in the surgery schedule, so we'll definitely keep you up to date on those. During and after surgery, your coach will go back out into the waiting room, and that coach will get updates throughout your surgery, when surgery gets started, each hour that you're in there, and then your surgeon will come out and talk to them after your surgery is done. It is important that your coach has your passcode. It's a 4-digit code that you'll receive when you go through pre-admission testing, and for some reason you lose that code, forget it, let us know so we can definitely give that to you. We do have Wi-Fi available for electronics, so that's something that your coach can use while they're here at the hospital waiting on you, and it also will work upstairs in your hospital room. So when you wake up, you'll be in recovery room, also known as PACU. When you wake up, you'll be in a hospital bed. You'll be in recovery room about 1 to 2 hours. It just depends on how quickly you're waking up. We'll be monitoring your vital signs, so your heart rate, your blood pressure, your oxygen. We're going to make sure you're waking up good. When you arrive to the ortho spine unit, we'll be checking those vitals pretty frequently. So on arrival, and then hourly ×3, and then every 4 hours thereafter. We will be doing a neuromuscular assessment, so we're going to make sure your hands and feet are still working, so we'll have you be moving those. Pain control will get your pain down to a tolerable level. You could have a little bit of a sore throat from the breathing tube if you receive general anesthesia. Your coach is kept up to date during this time. They cannot come to the recovery room with you. And the next time you see them will be upstairs in your room, and then this is the time that your room number will be assigned. So how are you feeling? You're going to have a decrease in energy level. Your body's using a lot of energy to heal after surgery, so it's important to balance that rest with activity. And you may want to limit your visitors once you get home because you're going to need that sleep. Anesthesia may take a few days to get out of your system, so you may remember little to none of even being in the hospital and even a couple days after surgery. You do want to begin with light foods for your first meal. Your stomach is still waking up from anesthesia, so you don't want to put anything heavy on your stomach. And your appetite may take a few days to get back to normal, so it's important to kind of force yourself to eat and definitely make sure you stay hydrated. We say call, don't fall. After surgery, you're at risk for falling because you've had anesthesia, you've been on pain medicine, you probably have an IV still in. That IV will be hooked up to the fluids until you start eating and drinking well, and then you'll just keep the IV in until you go home. You may have a drain in, you may have that ice pack hooked up to you, and then those compression devices, and then you could have some impaired mobility just to do it, from the weight bearing tolerance you're allowed to put on your leg. So what to expect? You're going to have some yellow socks on, yellow armband, you're going to have a yellow magnet on the door. You will possibly have your bed alarm on during your stay. We'll be rounding on you on a regular basis, and expectations, use your call light. Don't be afraid to push it. That's what we're here for. We definitely don't want you falling. We'd rather you push your call light for us to come and assist you. So we're going to have you rate your pain on a scale of 0 to 10. 0 is no pain, 10 is the worst pain imaginable, 5 is right in the middle. So we'll want to know that number of your pain. We use a multimodal pain management approach, which goes along with the ESR program. And basically what that is we use several different types of medications, and all those medicines work together to help control your pain better than giving you a large dose of narcotics alone. So this will be a new kind of pain. It's not going to be that bone-on-bone pain that you were having before. It's going to be more of a surgical pain. You do want to intercept that pain before it gets severe. You don't want to be a hero. Don't wait to take your pain medicine until it's hurting really bad, because then you have to play catch up and it will take, possibly half the day or longer to get your pain under control. Let the nurse know that if the pain medicine's not working, we can always call the doctor and see if there's anything else that we can give you. And of course, please ask to make sure you understand all the pain management efforts that are in place. Remember, we can't make the pain go completely away, but what we want to do is get it down to a discomfort so you can eat, sleep, work with therapy, and get home as soon as you can. We do all we can to ensure your comfort and safety. So what that means is if you are too sleepy or if your blood pressure is too low, we will not be able to safely give you your pain medicine. We're going to have to wait until you wake up a little bit more or your blood pressure goes up. Don't worry about getting addicted to those pain medicines as long as you're taking them as prescribed. Taking them as prescribed means you're hurting. So if you're not hurting, you don't take them. You'll know when it's time to start weaning off those pain medicines. The first few days are the roughest, so you're definitely going to want to take those pain medicines pretty regularly, and then you can start weaning down on them, as comfort allows. Being in unnecessary pain will actually cause stress on your body. It's going to tense up those muscles, slow down your healing. Then you don't want to get up, you don't want to move, and then that's going to put you at those risks for those blood clots. So remember, everyone's experience is unique and different. So if you've heard horror stories about someone having a joint replacement, don't think that's going to be you. As long as you follow all the instructions, you are going to do great. The next slides are going to be presented by Jennifer Baker.
Thank you, Sarah. My name is Jennifer Baker, and we're going to be talking about the therapy portion of your hospital stay, thinking about what's going to happen in the day or two following your surgery. We have two branches of therapy that covers in the hospital after these surgeries. One is physical therapy and one is occupational therapy. Physical therapy may begin the day of surgery, so we'll come up that afternoon. We'll teach you some lower extremity exercises if you've had your knee or your hip worked on, and we'll try to help you get up and move around and get out of the bed that afternoon. We will come up and see you once you're out of the PACU and into your room. So we'll help you walk with an assistive device, which we'll talk about here in a little bit if you need one, and you'll end up seeing physical therapy 1 to 2 sessions per day while you're here. The other branch of therapy that will come to see you is called occupational therapy. OT will see you the morning after therapy, and they have a little different focus. They tend to focus more on your activities of daily living, your bathing, your dressing, those kinds of things. So they'll show you some arm exercises if that's appropriate, help you with your bath or your shower that morning after your surgery, and help you talk about some precautions that you could take at home to make sure that your transition back home after surgery is safe. This next slide, we're going to talk about some of the things that you'll see during your hospital stay. Sarah's already mentioned several different pieces of equipment, but we're going to kind of go through a list so that you will be familiar with all of the things that you'll see after your surgery. The first thing is the IV pump. You've probably all seen those. It will have just some fluids running in, and the IV was started before surgery. The second thing is the vital sign machine, and I'm going to step over to this table so we can look at these things. The vital sign machine will take your blood pressure. There's a blood pressure cuff on it. There is an O2 sat monitor, which is this little piece, and you may wake up even with this on your finger. This reads the percentage of oxygenation that you're able to do from what you're taking in into your lungs that will transition as oxygen into your bloodstream, and it kind of is read as a percentage on this finger cuff. Since you all don't use oxygen before surgery, we're going to hope that you don't need it afterwards, but just because of anesthesia and the surgery and different things, the pain medicine, we will use oxygen while you're under anesthesia, and so you'll wake up with oxygen tubing in your nose. This is called a nasal cannula, and you'll wake up with that pumping some higher concentration oxygen into your nose. We'll want to make sure that this percentage is in the 90%, and as we're able to take the oxygen off, and we're going to hope you're still in those 90% even without the oxygen. So we'll wean you off of that fairly rapidly after surgery. That way we'll have a guide. All right, next we want to talk about the incentive spirometer. I'm going to put my glasses on, make sure I can see well. We've got a couple different kinds here. One, it looks like this, and if you've ever had surgery or hospital stay, you might recognize this. This is for you to practice some deep breathing, and again, that helps you to really move oxygen and transition that into your bloodstream so you feel good and strong. This you would, it has a hose that you're going to put your mouth on and take a big deep breath in, and that will pop this blue disc up in this cylinder, and we'll give you kind of a target range of what we want your volume to be as you take some deep breaths. There are a couple different kinds of pulse oximeters that we use here, so you may see this or you may see one that looks a little different, but they do the same thing, and we'll be able to explain that to you when you're up in your hospital room. All right, Sarah's already talked about the TED hose, or those elastic stockings, and the sequential compression devices. So we're going to move on to the shoulder immobilizer, which I actually don't see one. But when you come into the hospital, you'll already have been issued a shoulder sling with or without a bump. We've got a picture of it on the slides. If you're having your shoulder operated on, you'll have that sling either with you or we'll issue it to you after surgery. The other kind of immobilizer that you will see in the photograph on the slide is called a knee immobilizer, and every once in a while, definitely not very often, your doctor may be concerned about you getting your full extension back or the straightness of your knee following your total knee replacement, and he or she may ask us to use that knee immobilizer to help give you that extra little positioning into a straight position. By far, it's less likely for you to have that immobilizer because our surgeons all like for you to regain your strength and range of motion on your own instead of need that bracing for your lower extremity. Okay, the other thing I wanted to show you was, this is called a hemovac. This is just a little drain that if your surgeon is worried that you might have some drainage or oozing of blood or anything around your surgical site, whether it be your shoulder or your hip or your knee, they may pop in this little drain called a hemovac, and that's all it does, is it drains that blood and serous fluid out into this canister. If you see this, that doesn't mean anything went wrong in surgery. It just means that they want to make sure that that drainage comes out into this canister instead of pooling around that surgical site and appearing like a bruise after your surgery. So you may or may not see this, most of the time not. The next thing we want to talk about is this. This is called a polar ice machine. You will, if you have your knee operated on or your shoulder operated on, you will see this. It is an ice pack that you will have either tucked inside of your TED hose if you had a knee surgery, or laying over the top of your shoulder and kind of formed around your shoulder if you've had your shoulder surgery. This, we can put ice and water into this cooler. It will sit on the floor next to your bed and then plug into the wall, and then it circulates that cold water to this pad so you get that cooling effect. And we'll use this pretty much most of the time that you're here in the hospital. It can be removed for therapy, it'll detach and won't leak, and then we can reattach it when we get back after your walk so that you can continue to have that. If you feel like it's not cold, please let us know, because we may just need to refresh the ice in the cooler. Okay? All right, lastly, we want to talk about, last thing on this slide, the post-op dressing. This is called a Mepilex dressing. Thank you, Sarah. And this is an antimicrobial island with a clear dressing that is adhesive around the outside. So this will be laying over your incision, over your knee or your shoulder or your hip, and it can stay in place for 7 to 14 days. So it is water occlusive, it won't let germs in, it won't let water in, but it helps to trap that the surgical drainage on this island. This is an antimicrobial island, so it also helps to kill any bacteria that might have worked their way into that drainage. So that's a nice infection control benefit as well. So this can stay in place 7 to 14 days, like I said. So you may not even have this changed before you go home from the hospital. Often these, we may or may not see any post-operative drainage, and if we don't see drainage through this dressing, we probably won't change it because it can stay in place until it becomes saturated with fluid. So if you go home with this in place, you can just leave it there. You can take your shower, you don't have to worry about it, you just leave it in place until it needs to come off, okay? There's one of our surgeons that uses a different dressing than this. It just looks like the clear part of this plastic without that island. And so you may see just that clear dressing over the incision as well, and then that can stay in place until, unless there's any fluid underneath it, and then we would need to change it. Okay. Next, we're going to talk about the expectations after your surgery. And just as a thought, we're going to come bopping in wearing these burgundy scrubs because we're color coded and we all wear burgundy when we come in to see you. We'll come bopping in and say, let's get up and do your therapy, let's do your exercises. But we know that you may have not had your pain medicines, you may not have slept very well. If you feel like you need to talk with us about your schedule, if you tend to be an early morning person and would like to do your therapy early, or if you tend to not like to do things first thing in the morning, like to do things later in the day, then just tell us so that we can try to arrange our schedule so that we can work around your time frame. We will try to make sure that you have your pain medicine 20 to 30 minutes before your physical therapy session or your occupational therapy session. But remind us if you need that and it's due, we want to make sure we time that accordingly. We are going to, if you end up having to just tell us to come back later and you want to refuse, you do have the right to refuse any portion of your care here. So if you don't want us to visit you, you have the right to tell us no. But we will try our very best to come back later and try to work that in. If you miss one of your PT sessions, that is one of the 4 that you get during your hospital stay, we may not be overly concerned that that would affect you in the long run. But if you tell us no, that you don't want to do 3 of the 4, we're going to worry that you didn't get enough movement of your leg or walking after surgery, and we want to make sure that you get everything you need to put you on the road to your recovery. So just kind of be open with us and help us to help you. The discharge goals, the things we want you to accomplish. You're having these surgeries because you haven't been able to do the things that you want to do in your life, and you want to get back to some of those things. So we have some goals even from the very beginning, from the very first day after your surgery. Before you're discharged from our hospital, we want you to be able to get in and out of bed by yourself. You have a coach that's willing to help you, but we want you to be able to do those things without needing physical help. We want you to be able to walk 100 feet with a rolling walker. That applies to our folks that are having their hips or their knees worked on. If you're having your shoulder worked on, you won't be able to use a walker because one arm will be in a sling. But let's talk about that walking with the rolling walker for just a second. I've got one here. And this is a rolling walker. It's got wheels under the front legs and then kind of stoppers under the back legs. And we like to use this device because it's very sturdy. It will definitely hold your weight and not slip underneath you. But you also don't have to pick it up to move it. So you can slide it forward and then you can lean on it as much as you need to help you with your walking. After your hip or knee surgery, you will be considered weight bearing as tolerated, which means that if the very first time you get up to walk after your surgery, if you're not able to put very much weight through your leg and you need to lean hard on the walker, that's okay. So the first time that you walk may look something like this, where you scoot the walker, step forward with your surgical leg, and then catch up with your non-surgical leg. So it's kind of a walker, step, catch up, not putting much weight on your leg at all. But by the time you leave the hospital, or very shortly after that, you may be able to do something more like this, where you're putting a little weight on your leg and walking with a more normal pattern, but still using the rolling walker for some balance assistance. And that's fine. So we'll get you one of these to take home with you. If for some reason you don't want to have a rolling walker at home, or you have a lot of stairs and you'd like to try crutches, or if you just want to try something different, just let us know, and we can definitely use a couple of different options instead of the rolling walker. But we really like the rolling walker as a first choice for our hips and our knees. For the third goal, we want you to be able to go up and down stairs if you have to do them at home. And we have a practice set of stairs in our gym on the 4th floor that has handrails on both sides, and they're pretty traditional 3 steps or 3 or 4 steps like you would have going into your house or leaving your home. And we'll go into our gym and we'll practice that, simulating whichever side your handrail is if you have only one. And we'll practice that with you and your coach just to make sure you'll be safe getting in and out of your home. And then we want you to be able to bathe and dress yourself with little to no help. OT will work with you with some equipment that I'll show you here in a little bit to try to help you make sure you can bathe and dress yourself at home. And then we want your pain controlled back on your oral pain medication. So you might get some additional things. We'll be following that ESR that Sarah talked about. But when you go home, we want your pain controlled at those goal levels with more of what you can take at home and really control your pain on your own. Our knee replacement patients, we will talk about some range of motion goals. This is called a goniometer, and this measures joint range of motion. So for our total knees, we will bring this in when we're doing your exercises, and we will practice, when we're going through your exercises, we'll actually take some measurements. So regular range of motion or full range of motion, if you don't have arthritis, is 0 degrees of knee extension, so that would be with your knee all the way straight. And then normal knee flexion is somewhere in the 135 to 145 degrees of bend. So that would be if you could bring your heel all the way to your bottom. Many people that are having their knees replaced haven't done that in years. So we anticipate or hope that before you leave the hospital, you're going to be able to get your knee all the way straight and then flex it to approximately 90 degrees. And that would be like if you're sitting in a chair and with your thigh even with the chair and then your foot kind of directly under your knee. So that's kind of a 90-degree angle. At the end of your recovery, the components of the knee joint, the artificial knee joint that Sarah showed you the model of, the components of that knee should be able to go to somewhere between 120 and 125 degrees, and you'll work on that with your outpatient therapist. And that should get you everything that you want to do, like climbing stairs reciprocally or riding an exercise bike or kind of all those activities that you want to get back to after the knee surgery. So that's a goniometer for our total knee patients. For our total hip replacement patients, we will teach you the precautions after your surgery. And that's very important after a hip replacement. Depending on the approach, the anterior approach has a certain kind of precautions, the posterior approach has a different set, and we'll talk about those in the next couple of slides. And then for our shoulder replacement patients, the same thing. We would like for you to know all of your precautions, and that's going to be in the next slide or two, and we'll talk about that specifically. And then for everybody, we want your arrangements made to have a safe return home, and you'll go home the day after your surgery. So the anterior approach for our total hip replacement patients, there are several directions that you need to be careful of or not move your leg right after surgery. So let me see what the best place is for me to demonstrate this. Abduction of your leg is if you are coming out from midline of your body. So that would be like you're getting into your car and bringing your leg out to the side. You need to be careful of that. You need to turn and sit in your car and bring your legs in after you've had a seat. So no abduction of your leg, no extension of your leg. That would be with it down very far behind your hip. So when you're walking, we're going to start off walking with you catching up to that leg and not stepping past that leg. And then no external rotation of your leg. So after our anterior approach, we'll have you follow this set of precautions. And your doctor will advise you about when you can kind of relax those precautions and go back to your more normal motions and not have to worry about that so much. For our posterior approach, they're basically the opposite. So if you've had a posterior approach of your total hip replacement, we don't want you to flex too far, which is flexion past 90. So that's 90 degrees of your hip, so flexion past that would be more than that. So we would want you to avoid sitting in really low chairs and trying to get up. So you might need to be really careful about sitting on a low sofa. You don't want to internally rotate or adduct your leg, and that is the don't cross your legs kind of position, where you're bringing your leg in and then turning it in. So again, we'll go through those more specifically if that's your surgical approach that the doctor has chosen, so that, to make sure that you know all of those precautions before you go home. We're going to talk about the shoulder precautions. If you have had to have a reverse total shoulder, and Sarah showed you those models, you will need to wear your sling, which may or may not have what's called a bump. The bump is that pillow that holds your arm out away from you. If your surgeon wants you to have that, it'll be there. If he doesn't or she doesn't, then it won't be there, and that's okay. We'll use whatever they recommend. You'll need to have that sling on pretty much all the time for the first 3 weeks after your surgery, except when you're showering or doing your recommended exercises. The indications for a reverse total shoulder are if the rotator cuff is not repairable, if your arthritis is just too severe. And what happens with a reverse total shoulder is that it will allow us to advance your mobility a little bit more quickly because you haven't had to have that rotator cuff repaired, and you can kind of have pain relief as your primary goal. The regular total shoulder, which again was opposite with the ball on the socket like Sarah showed you, you'll also have to have a sling with or without the bump, depending on what the surgeon recommends. Again, you'll wear that for the first 3 weeks, and the precautions may vary depending on what kind of rotator cuff repair they had to do as well. For both our reverse and our regular total shoulder replacement patients, you need to make sure that you don't lean too much on that arm. It's non-weight bearing, so you want to have support at your elbow with a pillow, so you want it to kind of be relaxed, but not so much that you bear weight on it. So you should always be able to see your elbow. You definitely don't want your elbow to drop into what we call extension, or drop behind the midline of your body. So you need to be able to have it in your sling with a pillow underneath your arm, or under your elbow, so that you can see your arm and it's not dropping back. You probably will be more comfortable sleeping in a recliner. After these surgeries, elevation is really a nice thing to help with management of swelling. For our leg patients, if you lay down and elevate your leg on a pillow, that's elevating your knee. For our shoulders, if you elevate your head, that's elevating your shoulder. So you might feel like it's more comfortable to sleep in a recliner or propping your head and shoulders up in your bed to give you some of that elevation of your shoulder. We definitely want you to avoid lifting anything greater than 1 pound. So maybe a coffee cup that's half full, but nothing too heavy. So be very, very careful. You definitely want to use your other hand for all of your activities of daily living and anything that requires much lifting. The exercises that we'll do at the hospital after your surgery for you are things like hand gripping a ball, or maybe letting your elbow go straight, moving your wrist, and opening and closing your forearm. We will not do any shoulder exercises while you are here at the hospital, and your doctor will tell you when it's okay for you to start that. You'll most likely start your shoulder part of your rehab as an outpatient after you've gone home and had a week or two for that for everything to kind of settle. And whenever your doctor says it's time for you to go to therapy, that's when it's appropriate for you to do some movement of that arm. The next couple of slides we're going to backtrack just a bit and talk about what happens each day after surgery. We've talked about what our discharge goals are and where we want you to get by the time you leave our hospital, but we may have just kind of things broken up so you know what to expect day 1 and what to expect day 2. Most patients will start walking their very first time up with therapy. For our total hip replacement and total knee replacement patients, we'll use that walker like I showed you. With our total shoulder patients, we still want you to get up and walk, but you may not need an assistive device, or we might let you steady yourself with a cane because you have a sling on the other side. But we want you to be able to get up and move and walk about 10 feet that day of surgery, that afternoon. Again, for our lower extremities, weight-bearing status is considered weight-bearing as tolerated. And keep in mind that early activity after surgery helps prevent those scary things that Sarah talked about, like blood clots, the DVTs and the PEs. If we can help you get moving a little bit more quickly, the risk of that goes down. We'll have you performing ankle pumps several times throughout the day, 20 to 30 repetitions. Once an hour is okay while you're laying in the bed. And we want you to make sure you remember that when you transition after you've had anesthesia and when you've had maybe a little bit more pain medicine in your system, you can get a little bit dizzy or lightheaded when you transition between laying down and sitting up or sitting up and standing up. We're going to have you try to move a little bit slowly through those transitions to make sure you don't get dizzy or feel unsteady when you're trying to get up and move around out of bed. We want you to be able to sit up for all your meals. That's a great time for you to be out of bed. And then the day after your surgery, we'll make sure we practice on the stairs that we talked about. And we'll make sure you're trying to reach those goal levels of walking 100 feet, get out of the room, walk in the hallway. And then you'll want to take a shower probably the day after surgery, excuse me. Our rooms up on the total joint and spine floor have a nice walk-in shower. We'll use a shower chair. I'll show you some of the equipment that you may see so that you can have a seat and do everything you need to do, wash your hair, get a shower, all that before you head home. Just a thought about the bathroom though, while we're talking about that. We would like for you to be able to do what you need to do yourself to do your bathing and dressing. But the bathroom itself is a risk for falls location in your home. The spaces are tight. The surfaces can be wet. You're using, you either have a sling on or you're using a walker to try to negotiate those spaces, and that's different. So the first time or two that you navigate through the bathroom once you get home, have your coach with you. Not because you're gonna need physical help to do your bathing or dressing, but because just to kind of get the lay of the land and move around safely through the bathroom is gonna be important. Okay? And then the day of discharge, we'll make sure we talk to Sarah in case management and make sure your referrals are made for your outpatient therapy after you go home. And make sure you have your ride set up and you have your prescription. We'll talk about with Sarah all those things to make sure you have your plan. All right, the next few things we're going to talk about are some occupational therapy specific things that you might be able to use temporarily after these surgeries that will make things a little easier for you. So I'm going to show you a few things. On your slide, there is pictured a stocking donner. It's a piece of equipment that looks like a frame that you can put your TED hose over and kind of step into your stocking so that it can slide on up. The other things, I have several things here with me that might make things easier. This is called a long-handled sponge, and it if you have a shoulder replacement, it's very nice for reaching your back, reaching your legs, just because you're going to be trying to do your bathing and dressing with one hand, basically. So this is a nice piece of equipment to help you with your bath. This is a long-handled shoehorn, so that you cannot have to bend all the way down to your foot, but you can use that to slip into your shoes. This is called a reacher. This piece of equipment is very nice. It's to help pick up things from the floor when you're not moving around as well as you usually do, so that you can retrieve those items. There are a couple different kinds of these. Our occupational therapists like these with the pincher better. There's some that come with suction cups and those aren't as nice, but this is a very nice piece of equipment that you can use for a lot of things. And then this is a sock donner. This is a cool piece of equipment. You can put your sock over the end of that white piece of plastic and then hang that down and wiggle your foot in, and it will slide your sock on over your foot. So that's pretty slick. So if you're interested in any of these, make sure you ask your OT while you're here in the hospital and they can show you all that equipment. We have those pieces of equipment available at our Keystone Pharmacy, which is located where in the hallway where you've probably gone by the elevator to go up to see your doctor. And if you want something like that, they have those items available there. But you can also check on places like Amazon. They have everything. And there are also a couple places like, if you do Facebook, there are some Facebook groups that you can go into and look for those items that maybe somebody has used and doesn't need anymore if you are interested in that. The other pieces of equipment I wanted to show you are things that you can have in your bathroom to make things a little easier for a short time. The very first picture on that slide is elevated toilet seat. that goes over your existing commode and then has armrests so that it helps you raise up just a little bit so you're not sitting so low, and also has an armrest that you could push up off of if you need that for a little bit of help. And the next piece, we have one here. It's called a bedside commode. This piece of equipment is nice because it can be used, it has a bucket so you can use it as a bedside commode. If you take the bucket out, you can put this over your existing commode, and then it has the armrest and you can change the height. It's adjustable so you can make it as tall or as low as you want to, and it'll give you a little bit of a boost coming up off the commode, which is very helpful. The other thing you can use with it, if you have a walk-in shower, you can actually just set this inside of your shower if it's big enough, and then use that to do your shower on, so you have some place to sit and then stand back up if you need to. Okay, so that's the bedside commode. There are some other options as far as things to use in the shower. This is a shower chair. It comes with or without the back. If it's just the shower bench with just the 4 legs, it's not very expensive at all. The back makes it a little more expensive, but this is also nice to use in the shower. Again, it has adjustable legs. But the thing that our occupational therapists like the best of all of these options is on your slide, and it's the shower tub bench. It's a little more expensive, but if you have a tub shower combination, it sits across the part of the tub that you have to step over, so the bench comes outside of that, so 2 legs sit outside of that bench, and you can actually sit on the bench, bring your legs over, and then scoot in, and it is a very helpful piece of equipment so you don't have to step over your bathtub ledge to get into your shower. So that's very, very nice. We have one of those upstairs that you can practice with OT if you want to before you purchase that. Sadly, most insurance companies don't cover any of the bathroom kinds of equipment, so those are things that may have to be out-of-pocket expenses if you think that would help you for a short time after your surgeries. The guide for your daily activities after you leave us. We want you to use your assistive device, whatever your therapist has recommended. We would much rather you barely touch that rolling walker to get to the bathroom than to leave it behind and crawl on your furniture, because it's very hard to do that without limping. And we want you to really restore that normal gait pattern, and the best way to do that safely is to use that assistive device that your therapist is currently recommending. For our lower extremity surgeries, you'll use that rolling walker for the first week or 2 until you're really able to do that normal gait pattern, and then they'll transition you to a straight cane and then to no device at all. So be patient, use what they recommend. Well, you might now want to look around your house and put away any area rugs that might be a tripping hazard. That would be helpful even now to make sure you're safe once you go home. You want to have a good supportive chair with armrests. We talked about recliners. Recliners for our total shoulder patients are very helpful, but for our lower extremity patients, the doctors do not like for you to use your recliner for the first little bit of time after your surgery. You want to have a nice supportive chair that has armrests and then maybe an ottoman to elevate your leg on. So you don't want to sit in really, really low chairs, and you want to make sure when you elevate your leg that your knee is in a pretty straight position. And that recliner, when you have especially a knee replacement, when you bring the legs of the recliner up, your knee can rest in that little bit of a bend, and that's not particularly the best position for you to rest it in. So make sure you're talking with your therapist about your preferred place that you sit when you're hanging out at your house, so that they can advise you what the best position is for you. We definitely don't want you, if you've had a total knee replacement, we do not want you to rest with a pillow underneath that new knee joint, because that lets you rest in that little bit of a bend. And if you do that for a couple of hours to watch a ball game or to watch a movie, then when you go to stand up again, your knee is going to feel like it wants to stay in that little bit of a bend, and it'll be hard for you to get your foot flat and to not limp, which again, we want you to have that good normal walking pattern. So if you rest for that 2 hours with your leg in a straight position, then when you stand up, your leg goes to that straight position and you're able to have a more normalized gait pattern. Okay? If you do want to prop your leg up after that total knee or total hip, we want you to put that pillow underneath your ankle or long ways down your calf so that your knee rests in that straight position, just to kind of give you an example. Okay? You are going to want to gather all your clothes prior to dressing so that you don't have to go get anything and interrupt yourself. You might want to gather everything beforehand. For our shoulder patients, you might want to have some oversized button-up shirts or large neck t-shirts that you can put on over your surgical side and then use your more mobile side to come in around on the other. So that'll be helpful. You want to put your surgical leg or surgical arm in your clothing first. That'll make it easier. Again, OT will practice some of these things with you, so that'll be helpful. And then you want to wear slip-on shoes just to make sure you don't have to bend to get to those laces. A good slip-on shoe is very helpful. We don't want you to soak in a bathtub until your incision is completely healed. Those dressings that we showed you, the Mepilex dressing, is water occlusive and it won't let water go in, but showering is totally fine. But we don't want you to get underneath the water in a bathtub, because even if there's a little crack or crevice, there could be bath water that could get in there and be a risk for infection. So no soaking fully immersed underneath the water until your incision is completely healed, and you don't have to have a dressing on it at all anymore. We do want you to keep active. You want to move around every hour during the day. Don't get up and move during the nighttime. Sleep as much as you can sleep, but try to move around every hour during the day. You'll want to take short walks, increasing your walking distances as much as your comfort will allow, but take some short naps so you let yourself recover. And don't be too worried if there's a little bit of bruising around that surgical area. That's not uncommon. That will gradually go through the healing process just as your joint does. And swelling is not uncommon even for the first several weeks after your surgery. That's your body just trying to go through the process of healing. So use your ice, use your polar pack, use some movement. Movement will kind of help with that swelling as well, and use some elevation. Do everything you can do to kind of work on that swelling. If swelling is accompanied by redness or heat in that area or fever or some of the things that Sarah talked about, then you need to call your doctor. But if you're just noticing some swelling around your surgical site, it's okay to kind of self-treat unless it becomes something, unless there are other symptoms that go along with it. All right, the next thing we want to talk about is called Care Steps. Care Steps is a program that we use so our doctors can compare their surgical results with other doctors' surgical results around the country. So it's kind of a large database. If you are someone who uses their computer or is interested in helping us with some information like that, we'll have you take home this card that will help show you how to sign in. It'll require you giving your demographic information to kind of log in, and then you'll fill out a survey at 6 weeks after surgery, at 6 months after surgery, at 1 year, and then that data can help our doctors to know how their total joint replacement patients are doing compared with other patients in other parts of the country. So it's a very helpful kind of information for us to have. So we would appreciate your help with that, and if you're interested in that, we can make sure that you're a part. All right, this is my last slide. We're going to talk a little bit about the lower extremity exercises that we'll be doing here in the hospital, but they're pictured in your book, so you can actually get started with them before surgery if you'd like to, so you are familiar with them when you get here. The first picture on on the exercise page is ankle pumps. We've talked about those several times. Just moving your foot at the ankle in the flexed position with your shin muscles, and then point your toes with your calf muscles. Just the movement of your ankle pumping helps with circulation and to make you feel like you are less at risk for those things like blood clots and issues. You'll probably really like being able to move since you'll be in bed more than you're used to and things like that as well. So pump your ankles. We'll have you do that a lot. The second picture on this page is probably the most important exercise if you're having a total knee replacement. It is called the quad set. Your quadriceps muscle is the large muscle that moves, that runs down the front of your thigh and attaches to your kneecap. And then your kneecap attaches with your tendon to your shin. The quadriceps muscle is responsible for straightening your knee, but also for holding your knee in that straight position when you're in standing and controlling your descent as you move down to sit in a chair. So it's a very important muscle. It also is manipulated by the surgeon when he goes to do your total knee replacement. So us getting the function of that, both from a strength standpoint and for it to relax, to let your knee bend, is very important and probably the key in your total knee replacement rehab. So the quad set exercise is just squeezing that muscle so we move, so you kind of feel like your leg moves into that straight position. So you can do that with your leg propped in a chair and just flex the muscles so that your knee straightens and your kneecap comes up towards your thigh, and then relax. You can kind of do that in any position. You can, with your leg resting up on your coffee table, you can practice quad sets. With you laying in your bed, you can practice that. But if you're able to tune in to feeling that quadriceps muscle just flex and relax, it will help you with your total knee replacement rehab after surgery. The next one is called glute sets, and that is using the muscle over your buttocks to squeeze and tighten, and like you're lifting your hips if you're in a laying down position. And you'll see that picture noted on your page as well. That glute set exercise is very important if you have total hip replacement, because that muscle helps you to give stability to the back side of your hip joint. So that, again, that's just squeezing the muscle and relaxing the muscle so that you get used to the feel of doing that. The next one on the page is called hip abduction, and that's using your hip muscles with your legs straight to move your foot out away from the midline of your body and back in. So you're using the muscles on the outside of your hip to kick away and the inside of your thigh to pull back in, kind of like a windshield wiper if you're laying down. So again, hip abduction is hip out and then back in, okay? The next one on your page is called a heel slide. And that, when you're laying down, is just sliding your heel towards your bottom. So you'll flex your knee up in the bed as your foot slides towards your bottom. We'll do that several repetitions, just sliding your heel in the bed. And that is the position that we'll use that goniometer that we talked about to measure how straight your knee gets and measure how far bent you can get your knee. So that's how we'll take your measurements. And then the last one on your page is, on this page, is just called terminal knee extension. So with your knee over a rolled up towel or pillow, we'll rest your distal thigh and your knee on that prop, and then you'll kick your foot up so your knee is straight and let your foot come back down. So it's called terminal knee extension. So or short arc quads. We'll just straighten your knee and then let your foot come back down. Okay? And that's it for me, and I'm going to turn it back over to Sarah to let her finish the presentation.
Okay, so this next section is all about going home. We want you to have your ride available for discharge home. Usually around lunchtime, we're about ready for you to go home. We want you to plan ahead for someone to be with you for about that first week at home. We want you to shop ahead, have some easy to prepare meals. We don't want you standing in the kitchen for long periods of time trying to cook. You can also have your friends, bring you some food. Also pets, they're gonna miss you for a day or so, and so we want you to put those pets in another room. As soon as you get sat down at home, they can come and greet you and love on you. Those anticoagulant medicines, the blood thinners we talked about earlier, so if it's just aspirin, that's over the counter. If it's something like Eliquis or Xarelto, that is something that your doctor will give you a prescription for. And we'll make sure that your insurance covers it and your pharmacy carries it. The follow-up appointment, we'll make sure that is arranged and confirmed. And then those staples, if those were applied, they will be removed in about 14 days, 10 to 14 days at your follow-up appointment. We do want you to create a home base. Keep your phone with you at all times. If your family or coach friend, they do leave you for a few hours and you fall and you don't have that phone with you, we don't want you, laying on the floor for hours until they get home. So keep your phone with you at all times, no matter where you go, even if someone's home with you. Don't isolate yourself. Put yourself in a centralized location so you can all sit together. Keep items you use often, like your water, your TV remote, any books you like to read. We do, however, want you to keep your pain medicines in another room. Reason for that is you may take a pain pill, you drift off to sleep, you wake up a few minutes later, and you don't realize that it's only been a few minutes and you take another pain pill. We don't want you to do that for sure. Actually getting up, walking, and moving can help with that stiffness and help with some of that pain. So going to a skilled nursing facility is actually the thing of the past. On the rare occasion, some of our patients do go to rehab, but it's very rare. Basically, we really like you to go home. You can, move a lot more in your own home environment. You're more comfortable. You're at less risk of infection. You're not around a bunch of other patients. And so typically you will go home, but if it's something that our therapist, your surgeon, have all discussed that going to rehab would be the safest thing for you, then we would do that. But just plan on going home, usually with outpatient physical therapy. On occasion, we can also do home health to come to your house if you don't have a ride to therapy, but our preference is going to outpatient facility for your therapy. We do have the Daisy Award and Rose Award here. It's for our staff. Daisy's for nurses, Roses for all other staff members. And what that is just a way for you to recognize them and thanking them for the care that they've given you. So we can give you a nomination form while you're here at the hospital, or you can go directly online and nominate them through our websites. My Health One is a centralized location for your health information. Basically, it's kind of like the health portal you might have at your primary care physician's office, and you can look up lab results and reports, and also has some other things on there that you're able to do. And we will give you information about that with your discharge instructions. Shared decision making. So what this is saying is you and your doctor have discussed the surgery, or you've talked to the care coordinator, and you've discussed all the benefits and risks of having the surgery. But if you have any questions throughout your hospital stay, that is what we're here for. So definitely don't be afraid to ask. How was your visit? Nowadays everything has a star rating, and so we'd love to get your feedback of how your experience was. So Google, Facebook, and Yelp are the three main places people tend to want to go. And then my contact information is displayed on the screen, and you've got my contact information. So if you have any questions from here on out, this is what I'm here for. And we just want to thank you again for watching, and we hope that you have a great recovery and a successful experience.